This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, this is an extremely dense cataract. I don't think we can get a more denser, blacker cataract than this is. She's a 70-year-old lady who is diabetic for some time, and the cataract surgery has been delayed for a significant number of years, and this is going to be a tough ask. Through this case, I'd like to answer a few questions. Number 1, how tough it's going to be to crack the thick leathery posterior plate in such cases? And if it doesn't crack, how to go about it? Number 2, how to ascertain the right depth of the groove so that it can be cracked easily? And are there any potential pitfalls in identifying the right depth? Number 3, I get a lot of comments on my channel which ask that how do you deal with the corneal edema which we see after using excessive PHACO energy? Now, do we really get corneal edema after using excessive energy? There's the third question which I'm going to answer to this video. The machine which I'm using is my old Infinity machine, but I'm using a balance tip with the Infinity handpiece. The idea is the balance tip performs better as far as the cutting ability is concerned, and it doesn't get clogged. The design is almost same. It's a 45 degrees Kelman bend tip, which is very efficient in cutting. I begin the surgery with we've already done a rhexis, which is about 5.5 to 6 millimeter. This is what we aim for in very dense cataracts. I'm doing gentle iridissection using very little amount of fluid, and I can see that the nucleus is mobile and it's free from its attachment to the bag. So now is the time to divide the nucleus. The strategy which I'm going to follow in this case is going to be the divide and conquer technique. This is a classical 4-quadrant technique. And in this case, let me just clearly demonstrate to you how the lens fibers orientation would be as we go deeper and deeper. So let me remind you that the visibility is not great because of the color of the nucleus. It's very dark brown or black, and it's about grade 5 or grade 6 nucleus. But bear with me. Thankfully, the pupil is very well dilated and the corneal clarity is extremely good. So that should help us to see things better. So one important change which I would always do when I'm dealing with the hard cataract is expose the tip a little bit longer so that more of the titanium tip is exposed and I can have a very long and slightly thinner grooves. The nucleus is stabilized with my second instrument as I begin trenching. This is what I teach to all my resident doctors and trainees, to use the second hand to stabilize the nucleus. This is going to help us when dealing with much more complex situations where the nucleus would be mobile. So it's always better to use the second instrument just to place it on the nucleus. It adds to the stability of the nucleus as you're sculpting. We have to be mindful of the fact that we shouldn't physically push the nucleus, but let the ultrasound energy to cut across the nuclear tissue. The ultrasound energy is so efficient with the right tips, it can melt cataract of any density. So we need to understand to use this efficiency of the machines. So the nucleus is rotated 90 degrees as the grooves are being progressively deepened. So at this point, there's a slight change in color in a small area of the groove. You can see the area which is proximal to it has got these horizontal striations, but the small area has become much more darker in color and the striations of the lens fibers are absent conspicuously. So just replenishing some OVD helps us to visualize these things better. How much deep should we aim at when you're trying to do sculpting in these dense cataracts? I think the color change we noticed in this small area, that should be the goal. horizontal striations in the lens fiber should disappear and the color has to be much more darker. That should be the goal. We are probably maybe 100 microns or 150 microns away from the posterior capsule. That should be the goal when we progressively go on trenching. The more deeper the groove we have, it's much more easier to break the posterior plate. That's the logic for going so deep. So we're almost going 90% depth. And identifying the end point in these dense cataracts is a challenge because we don't have any underlying cortex epinucleus. Directly we have a pure posterior capsule. If you're too deep, we are likely to go into the posterior capsule as well. So there's a very thin line which is very difficult to identify. But just the absence of these fibers and a darker color is one of the hints which I look for. Well, at this point, I'm thinking that the depth is good enough. But what I have not realized here is the central 3mm zone, the color is slightly different. You can see that it is much more lighter compared to the darker peripheral areas of these grooves. When you look at all the grooves, the point at which they culminate in the central 3mm, that part still has a color which is slightly more browner compared to the blackish and the darker zones in the peripheral part of these trenches. This was a clear sign that this part is not yet deep enough. But this is on hindsight. When I was doing surgery, I could not differentiate this difference. So let's see how things turn out. So I'm using two long Sinskey hooks so that I get access to the posterior plate when I'm going to crack it. I'm using these two instruments and trying to place them as deep as possible. And the first attempt, the second attempt, and finally the third attempt, I'm successful in separating most of this part of the groove except for the central part. You can see that the central part is still hinging on. Again, the central 3mm or 2mm was still not deep enough. So the nucleus is rotated 90 degrees and the same two instruments that are used to separate the fragments. During lateral separation, the same problem. The peripheral part of the groove cracks in very easily, but the central attachment refuses to budge. The nucleus is rotated again, and the third crack could not be achieved successfully. And there is also a problem with visualization because of the overlying cortex. So I thought I'll go ahead and use my PHACO instrument to aspirate it and also try lateral separation using the PHACO tip and my second instrument. I wasn't able to get a good hold as I'm trying with the PHACO tip as the nucleus was melting and I couldn't achieve the lateral separation. And here I could get some amount of lateral separation, and although part of the apex was still attached, I pull this fragment out and start to eat it. So by doing this, I'm creating sort of an space within the bag. It's sort of debulking. This fragment cannot be engulfed in toto because its posterior plate is still not broken with that center of attachment. But nevertheless, the bulk of this fragment is eaten off and now we have a space within the bag. The further maneuvering will be much more easier. OVD is refilled into the anterior chamber. I go in with my PHACO tip and my second instrument, try to lateral separate. And I couldn't separate this quadrant. I rotate and try with a more freer fragment, and this I could flip it up. The apex now could be somewhat separated with my long Sinskey hook. And because there was space in the bag, I could flip up the posterior base of these fragments where it is attached, and then I could PHACO that bridge which was holding these two pieces together. So now one piece is free, the large bulky nucleus is then maneuvered out of the bag into the central safe zone and then it is being emulsified in a very controlled manner. Although it's very big and very dense, with the modern machines and with the torsional energy, we can cut it very efficiently and emulsify without much trauma to the endothelium. Note as it is being done, there's hardly any chatter. Progressively the size of it gets smaller and smaller, eventually deepens. So now we have got the last two fragments which are attached. And I'm just trying to do a lateral separation by holding them. Again, the bridge between these two fragments is still attached. And finally, I could separate these two pieces, and one of the pieces is then taken out and emulsified in a very controlled manner. Again, please note that there is hardly any turbulence, and you can emulsify the densest of the cataracts in a very controlled manner. And as the chamber is being refilled, please note the main incision. There is absolutely no evidence of any thermal injury, like any wound burn, in spite of having used significant amount of energy. Last two fragments, the bridge between these two fragments is gently maneuvered anteriorly and then PHACO'd. So the two fragments are now free, and each of them is emulsified in a very controlled manner. There is some amount of cortex, and it is aspirated using the bimanual I&A. The planned multi-piece lens is placed into the bag. That's it, the case is done. Now, these are the energy levels which were used during the PHACO. It's quite significantly high, but when we look at the first post-op day, it's almost as if the case was a routine one. There are hardly any corneal edema, and the patient is absolutely fine. To summarize, I think let's get back to all the three questions. Question number 1, is it tough to crack the posterior plate? Yes, of course it is tough. In spite of going as deep as possible, like maybe 90% to 95%, the last few microns, the plate can still bother us a lot. So it's not going to be easy. The only solution would be you try to sculpt as deep as possible. In this case, as we noted, the sculpting was deep enough in the peripheral parts, but the central part was still not deep enough, and the central 2 to 3 millimeter was the hinge where the posterior plate was not giving away. And if it does not give way, now how do we go about it? As was demonstrated in the case, we need to manage to remove at least one piece somehow. Once the bag becomes relatively empty, it's always possible to flip the base up and then PHACO that small attachments or bridges which are holding all these three pieces together. That's a very easy and simple way to break the posterior plate. The only caveat in this is that it cannot be done when all the fragments are there in the bag. One of the fragment has to be pulled out and emulsified. Now we have space to introduce our OVD and the cannula to push the base up. And once the base is up, we can very carefully emulsify and destroy these bridge or connections which are holding these three pieces at the base. That's a very simple and easy way to divide these fragments. Now, question number 2, how do we assess the depth in such dense cataracts? Well, as I've described in many of my previous videos, as we go deeper to the lens thickness and are nearer the posterior plate, the horizontal lens striations, they disappear. At the same time, what we need to observe is the color. The subtle color changes are there, especially in these brown and black cataracts. The more darker the color is, the more thinner the plate is. The more lighter or browner the color is, it is indicative of still some nuclear substance present here. So as was evident in this picture, you can see the color in the peripheral part is significantly darker compared to the central 3 mm zone. This is slightly reddish or brownish compared to the near black zones in the periphery. So these are subtle signs which tell us that the central part required a little bit more sculpting. If I had done that, the lateral separation would have been much more easier, and the central bridge which was holding all these four quadrants together wouldn't have been there. And lastly, it's a common belief that using excessive energy is going to cause corneal edema. The fact is, the plane at which we deliver ultrasound energy is much more critical rather than the amount of energy which we have used. Number 2, the most critical factor which eventually causes endothelial damage when you're managing such cataracts is the turbulence in the antechamber. The lens fragments which are floating around can come up and hit the endothelium. The mechanical trauma is the one which is responsible primarily for the corneal edema on the first post-op day. If you are able to control the amount of turbulence during quadrant removal, and if your plane of emulsification is much more posterior, you can be rest assured that in spite of using a significantly high amount of phaco energy, as was done in this case, the cornea can still be crystal clear on the first post-op day. Of course, we need to use as much OVD as possible at every opportunity. In this case, you could have observed that I used OVD after emulsification of every fragment. That little effort is required to ensure that you have got clear corneas on day 1. So that was it. Thank you for your attention and hope you found this video very helpful.